This is the end of the meeting, almost the end of the meeting, and I'm going to discuss about the end of the liver. So those are my conflict of interest. So several speakers this afternoon have shown that the natural history of cirrhosis is characterized by a state of compensated cirrhosis followed by complications. And as the complications accumulate, the life expectancy decreases. So cirrhotic patients can develop variceal bleeding, can develop ascites, then refractory ascites, and then bacterial infections and so on. So this is a classical view of the natural history of cirrhosis. But major improvements have been achieved in the management of cirrhosis. I just would like to give you an example, which is management of variceal bleeding. You can see here one study comparing two periods, 1981 to 1982, to a second period with the same group, 1988, 10 years later. And you can see that the in-hospital mortality during the first period was of almost 30%, and it dropped to 20% in 10 years. And if you have a look at a more recent randomized trial in variceal bleeding, in-hospital mortality is now less than 5%. We also have achieved major improvement in the management of bacterial peritonitis. Same example with different studies reported during different time periods. The in-hospital mortality was 62% in 1986, and in more recent years, in the 2000, it was 10% or less. So the picture of cirrhosis has changed, and a new entity, a syndrome, has been defined in 2013 by a European group, and this syndrome is the so-called acute and chronic liver failure. So basically, acute and chronic liver failure is defined by cirrhosis with or without complication, and the rapid onset of organ failures, and relatively poor prognosis. So you can see here the picture of a patient with a relatively stable condition, and at a given time there is a precipitating event, but not always, and then the patient develops organ failures and has a very poor prognosis. So what is acute and chronic acute and chronic liver failure is not, of course, acute liver failure, namely liver failure in a patient with underlying normal liver or non-cirrhotic liver. ACLF is not a decompensation of cirrhosis, namely ascites, variceal bleeding, etc. And ACLF is not alcoholic hepatitis, even if patients with alcoholic hepatitis can develop ACLF. ACLF, again, is a patient with an underlying cirrhosis with the occurrence of organ failures or a system and a high mortality rate, which has been arbitrarily defined by a 28-day mortality of 15% or more. So this syndrome has been defined on the basis of a large series of cirrhotic patients, more than 1,000 patients in Europe, recruited in 29 centers. And among these patients, 415 developed ACLF, and the remaining patients did not. So ACLF can be classified into three grades of increasing severity. The definition of grade 1 is not very easy to deal with. This is single kidney failure or single failure of the liver, which is determined by bilirubin. We'll discuss about that. And creatinine ranging from 1.5 to 1.9, or a single cerebral failure and creatinine ranging within the same limits. Grade 2 is easier. It's 2 organ failures, and grade 3, 3 or more organ failures. So there's a problem with the definition of organ failures. Liver failure is defined by bilirubin over 200 micromole per liter. Kidney failure by creatinine is very simple, more than 180 micromole per liter. Coagulation failure is defined by either an increase in INR over 2.5 or platelet count less than 20 giga. Circulatory failure is defined by the use of vasopressor as well as in the general ICU. Cerebral failure in this context is defined by grade 3 or 4 encephalopathy, and respiratory failure by PaO2 to FiO2 ratio lower than 200. So I have difficulties with this definition between liver failure. High bilirubin level is not always a marker of liver failure. You can imagine a patient with a stone in the common bile duct. He has bilirubin, an increase in bilirubin, but this is not liver failure. And same thing, coagulation failure can be the result of impaired liver function. But this is a simple definition which is now widely used. There is a clear correlation between the severity of ACLF and mortality. Patients without ACLF have a low mortality rate at 28 days, 5%. And the mortality increases quite linearly as the grade of ACLF increases, reaching about 80% in patients with 3 or more organ failures. So here, the mortality is very high. The profile is exactly the same when you consider the number of organ failure, known again 5% mortality, one organ failure 15%, single kidney failure is a little bit higher, 17%, two organ failure 32%, and almost 80% in patients with 3 or more organ failures. So who are these patients with acute and chronic liver failure? When you compare the patients without ACLF to the patients with ACLF, patients with ACLF are younger. The cause of cirrhosis is more frequently alcohol. They have more frequently ascites, bacterial infection. It's very important to note that 23% of the patients did not have previous episodes of decompensation, so they enter in the disease very abruptly with organ failure. And it's also interesting to note that 43% of the patients do not have any identifiable precipitating factor. So if you look at the lab, patients with ACLF, and it is not surprising, have higher bilirubin level, higher creatinine level, lower sodium. They have a lower platelet count, and there is an underlying inflammatory process which is expressed by higher leukocyte count and a higher rate of CRP. The prognostic factors of patients with ACLF, there are 2 steps. First, predictive factors of development of ACLF after enrollment, and the patients who are at risk of developing ACLF are patients with a high Cliff-SOFA score, which is the SOFA score which has been adjusted for variables of cirrhosis. I will not go through details. High leukocyte count, and ascites at admission. Ascites is an important risk factor. And now when patients have ACLF, risk factors for death are Cliff-SOFA score, which is a very useful tool, and high leukocyte count, which is a marker of inflammation and/or sepsis. So the mechanisms are complex, and many studies have been conducted in recent years. So its mechanisms have been clarified. Again, I will not go through details, but bacterial infection probably play an important role in the initiation of systemic and portal circulatory dysfunction, which play a role in the initiation of organ failure. Acute viral hepatitis can be a precipitating factor, as well as drugs such as paracetamol, which is widely used. And surgery is also a source of infection, encephalopathy, and ascites, and can precipitate ACLF. So, a cartoon to summarize the mechanisms involved in the ACLF. A patient has cirrhosis with portal hypertension. Portal hypertension is a source of bacterial translocation or translocation of bacterial products, which result in cirrhosis in an inappropriate inflammatory response. We thought during many years that cirrhotic patients were allergic, and this is the opposite that occurs in these patients. After a trigger such as a bacterial infection, there is now accumulating evidence that there is a dysregulation of the immune system with inappropriate inflammatory response with release of cytokines, chemokines, which induce microcirculatory dysfunction, impairs oxygen supply, and then, in the end, organ or system failures. But portal hypertension is also a source of hyperkinetic syndrome, which is responsible in the end by an activation of renin, angiotensin, intense renal vasoconstriction, and hepatorenal syndrome. So now what about the management? Each organ failure can be managed independently. Circulatory failure with vasopressors, renal failure, terlipressin, renal replacement therapy when needed. Cerebral failure, rifaximin does not really have a place in these patients with an acute and very severe condition. Albumin dialysis, we will discuss about this. Respiratory failure can need mechanical ventilation, and there is potentially a place for rescue transplantation. Indeed, the problem is that these patients have cirrhosis. They have impaired liver function, portal hypertension, an acute complication, organ or system failures, and then we enter in a vicious cycle where impaired liver function promotes organ failures, and organ failures contribute to further deterioration of liver function. So how to exit from this vicious cycle? Again, we can manage each organ failure independently, but it has been suggested that extracorporeal liver assist devices could help improve the prognosis of the patients. There has been a control study with MAS, which is an albumin detoxification system, you know, comparing patients with MAS and patients with a control group, patients with ACLF. The MELD score was similar in the two groups. The proportion of hepatorenal syndrome was high. The decrease in bilirubin was higher in patients with a MAS, which is normal because MAS removes bilirubin more efficiently than a conventional renal replacement therapy, for instance. There was a decrease in platelet count, which is a well-known complication of MAS system, but 28-day survival was similar in the two groups. So clearly, it does not seem to be helpful in patients with ACLF, and the same results have been observed with another trial with another system, Prometheus, and negative results. So transplantation is probably the best option. In recent years, several series have been published with patients transplanted with ACLF. You can see here a word of caution showing that, this is a French study, showing that the prognosis of patients with ACLF grade 1 or 2 transplanted in emergency is not really different from the prognosis of patients without ACLF, but a difference appears in patients with grade 3 ACLF with only 60% survival at 90 days. Recently, there have been more enthusiastic results with, again, a French study, if I remember well, with some of the groups which were included in the first study, suggesting that ACLF can be very safe with more than 80% survival in patients with ACLF grade 3, provided the patients are selected. And there are unrealistic messages, in my opinion. This is the last study, which has been published based on the UNOS registry database in the US, suggesting that good results can be achieved in patients with 5 or 6 organ failure. I really do not believe these results can be generalizable. Because, and this is probably due to problems with the definition and the poor quality of the UNOS database with many bias. So I would not recommend to transplant patients with multiple organ failure. The results are bad. So take-home messages. ACLF is cirrhosis plus organ failure plus a poor prognosis. The definition has been clarified by the EASL CLIF consortium. The definition of liver failure by bilirubin level is still questionable. Interestingly, no previous decompensation was observed in 23% of the patients. There was no precipitating event in 43% of the patients. High leukocyte count is associated with increased mortality. Each organ failure can be managed separately, but extracorporeal liver assist device does not seem to be efficient. Transplantation is an option in the male era, but the limits need to be defined to avoid futility, and prevention is a very important step in these patients, and several studies are in progress. Thank you for your attention.